We're talking about cardiac stress testing today. Who's a candidate for a cardiac stress test?
For cardiac stress tests, we will use those who are having symptoms. And by that I mean chest pain, shortness of breath, the people that we suspect may have coronary disease. And we use the stress test in order to risk stratify them or put them in a high risk or a low risk category.
Is a stress test the only way to determine if you are at risk for heart disease?
No, it's not the only way, but it's a good way because it's non-invasive. So as we spoke about earlier, the coronary angiogram and all of that, this is kind of a precursor because the coronary angiogram is an invasive procedure, it has risks,
right.
But with these what we can do is we can do a non-invasive way of looking at the heart, looking at the patient, looking at the EKG, and putting them into a higher risk where we say, maybe we'll go to the coronary angiogram, or a lower risk, saying that probably not your heart.
So what kinds of stress tests are there?
So there's three main types. There's a regular exercise stress test, which is a test where we set someone up on a treadmill, we put an EKG on them, and we have them exercise, and we push them, and we look at the EKG, and we listen to the patient whether they're having a reproduction of their symptoms. Then there's a stress echocardiogram, which is the same test, but pre-test, before we put them on the treadmill, we look at the heart, see how it's functioning, and then post-test, we look at them, and during the test, really, with the EKG, and we see if there's any abnormalities that are caused with stress.
And are there any new kinds of stress tests on the horizon, or are those the standard bearers here?
Well, the third one I didn't talk about is really the nuclear stress test, which is used quite commonly, and so with that, it's a radioisotope, but at low levels that don't cause a lot of reactions in humans at lower levels that we use. And what that does, it looks at perfusion by the amount of isotope that's picked up by the heart muscle. And you can imagine that if there's a narrowing in one of them, you don't get as much isotope in that area compared with the areas that do have good perfusion.
And as a cardiologist, which one do you prefer? Or are they all really good?
Well, I think they're all good and they all have their risks and benefits, and it really depends on the patient. And so I don't have one that I necessarily prefer over another, but they're all useful as long as you're using them in the correct patient.
All right, Dr. Tim Malins, thank you very much. And for more Your Heart and You segments, head to our website, rochesterhomepage.net.